This is JAPI, and welcome to JAPI Podcasts.
Welcome to the JAPI Podcast of October 2024 issue, JAPI Volume 72, Issue 10. I am Dr. Manisha Sahay, your host for today. This issue of JAPI has some really interesting articles. It includes 7 original articles, 2 review articles, 1 update article, 1 position statement, 1 point of view, and 7 unique case reports, and also 1 letter of correspondence. So let us discuss all these in detail. The first original article is titled The Incidence of Long COVID-19 at 12 to 18 months Following Delta Wave of Coronavirus Disease 2019. It's a hospital-based registry by Karthik Mittal et al. Long Coronavirus Disease 2019, Long COVID-19, also we know it as, or the post-acute sequelae of COVID-19, PASC, has emerged as a major clinical problem and has affected millions of people. It is defined as signs and symptoms that occur during or after acute COVID-19 and persist for more than 30 to 90 days, unable to be explained by any other alternative diagnosis. Long COVID-19 is characterized by pulmonary complications of COVID-19 as well as many extrapulmonary manifestations like fatigue, feeling of fever, low energy, etc. There are limited and short duration studies from India that have prospectively identified the incidence of long COVID-19. Therefore, to prospectively determine the incidence of long COVID-19 in patients hospitalized during the Delta variant COVID-19 wave in India, this study was done with a follow-up of 12 to 18 months. The study method included a prospective registry of all patients with COVID-19 who were admitted to hospital from April 2020 till present date. The patients for the present study were recruited from January to July 2021 who presented with influenza-like symptoms and were screened with RT-PCR according to national guidelines. The cases were managed according to Indian national and international protocols. Follow-up was conducted for all patients discharged alive from the hospital, either in person or telephonically. A 5-domain, 5-scale European Quality of Life Questionnaire, commonly called EQ5D5L, was used to identify general symptoms in all the follow-up patients. The 5 domains of EQ5D include evaluation of mobility, self-care, usual activities, pain or discomfort, and anxiety or depression. For identification of specific physical infirmities, the modified version of Birmingham Symptom Burden Questionnaire was used. SBQLC. That was the questionnaire used. It's an extensive symptom-based questionnaire focusing on 16 domains, like domains of breathing, N is equal to 7, pain, N is equal to 4, circulation, N is equal to 5, fatigue, N is equal to 4, memory, thinking, and communication, N is equal to 10, movements, N is equal to 3, and muscle and joints, N is equal to 3. The patients with symptoms of respiratory illness were excluded. Now, coming to the results, from January to July 2021, that was the period of second wave of COVID-19 in India, 8,680 suspected patients were evaluated for SARS-CoV-2 infection by RT-PCR test. 1,641 of these were virologically confirmed for COVID-19 and 388, that is 23.6%, were hospitalized. The majority of patients were men, that is 250, constituting 64.4%, and 161, that is 41.5%, were aged over 60 years. The important comorbid conditions were hypertension in 42.8%, diabetes in 38.4%, cardiovascular disease in 17.3%, and asthma or COPD in 5.9%. The median duration of hospital stay was 8 days. In-hospital deaths occurred in 75 patients, that's 19.3%. 3 patients, that's 0.8%, were transferred to hospice care, and 310 patients, that is 79.9%, were discharged to home care, and they were eligible for follow-up. The follow-up evaluation was performed at 12 to 18 months, a median of 15 months after discharge. During the follow-up, 9 patients, that is 2.9%, died, and 40 patients, that's 12.9%, were lost to follow-up. So among the remaining 264 patients, the incidence of long COVID-19 using WHO criteria was 45. Comparative analysis of patients with and without long COVID, that is 45 with long COVID and 219 without long COVID, showed that women were having more long COVID, 60% versus 33.8%, and this was statistically significant with a p-value of 0.037. The mean age was higher in those with long COVID, 57.2 plus minus 15.7 years versus 54.8 plus minus 15.5 years. Again, p-value was 0.01 and significant. Among the people with long COVID, those of oxygenation with non-rebreather masks, 17.8 versus 7.3%, was more common in those with long COVID, and also in those with non-invasive ventilation, that's 11.1% versus 3.2%. So P was again 0.02. So what was the conclusion? The study showed that the incidence of long COVID-19 in patients with moderate to severe COVID-19 hospitalized during the Delta wave in India is 17% at a median 15 months follow-up. So it's a significant number, 17%. The incidence is significantly higher among women and among older patients. It is also significantly higher in patients who had prolonged hospitalization in ICU, longer oxygenation, and higher deployment of non-invasive ventilatory support. The limitations of the study include a small sample size, single-center design, data from a single COVID-19 wave, limited follow-up, and diagnosis based on questionnaires. However, the protocols similar to present study have been used in most previous studies of long COVID-19, making the data comparable. So this was the first study. Now the next article in this issue of JAPI is also on COVID and is titled The Persistence of Coronavirus Disease 2019 Symptoms in Post-Acute Phase. Does age, sex, comorbidity, and severity of infection have an impact? The author of this study is Manisha et al. To the post-coronavirus disease, the persistence of symptoms and development of complications are frequently encountered clinical problems due to multiple waves of pandemic over the past 3 years across the world. So identifying risk factors would enable us to direct our limited resources towards the subgroups requiring long-term follow-up and management. So with this prospective observational study, it was aimed to establish a statistical correlation between the persistence of symptoms, that is dyspnea, myalgia, and fatigue, and the most 4 attributed risk factors for prolonged recovery, that is severity of acute illness, elderly age, presence of multiple comorbidities, and female gender in the Indian population. So here 300 patients with positive COVID RT-PCR test or antigen tests were enrolled over 10 months from December 2020 to October 2021. The symptoms were recorded at baseline and they were followed up with pre-designed questionnaire to assess their persistence at 1, 2, and 4-month intervals post-recovery from COVID. The severity of acute illness was the single most important determining factor of persistence of symptoms. The correlation observed between average number of severity of persistent symptoms increased with female gender, increasing age group, and presence of multiple comorbidities was not significantly associated with the exception of persistent fatigue in females at 2 months interval. So what was the conclusion? It was concluded that patients with history of severe acute illness should be followed up closely for prompt identification and rehabilitation of these cases. So this brings us to the third article again on COVID, which is coronavirus disease 19 associated mucormycosis, a single center observational study of 69 patients. This was by Dhirendra Shivaprasad Yadav et al. This is an original article from a single center which studied the clinical presentation, risk factors, complications, and in-hospital outcomes of patients with coronavirus disease 2019 associated mucormycosis. A retrospective study was done on 69 COVID-19 patients admitted with microbiologically proven mucormycosis. All mucormycosis patients had RT-PCR confirmed COVID-19 infection. Their mean age was 52.8 years, with mucormycosis developing in 73.9% within 30 days of COVID-19 infection. Out of these, 10% were positive even at admission. Rhinoorbital cerebral mucormycosis was the most common, 40.3%, followed by rhinoorbital, 37.3%, and sinonasal in 22.4%. Diabetes mellitus was present in 98.6% of patients. The common symptoms of mucormycosis were facial pain, headache, facial swelling, and vision loss. During COVID-19, 88.4% and 52.5% received immunosuppressive treatment and zinc sulfate respectively. 34.7% needed intensive care unit admission. The mortality rate was 26.1%. And what were the factors associated with mortality? The significant factors were the presence of chronic kidney disease, leukocytosis, ophthalmoplegia, oral or palate ulceration, current need for invasive ventilation, and past duration of oxygen therapy and zinc supplementation. The patients with current COVID-19 infection had severe disease with increased need for intensive care, 57.1% versus 14.5%, and also had a higher mortality, 57.1% versus 22.6%, compared to mucormycosis patients with previous COVID-19 infection. So what was the take-home message? The take-home message was COVID-19 co-infection predisposes patients with mucormycosis to severe disease with a higher mortality. Now we've had 3 articles on COVID. Now let us get out of COVID studies and shift to hypertension and stroke. The next study is entitled A Study on 24 Hours Monitoring of Blood Pressure in Acute Stroke and its Correlation with Short-Term Neurological Outcomes. And this is by Sunali Bhowmik et al. This is an original article from a single center which studied the correlation between 24 hours blood pressure monitoring and short-term neurological outcome. A prospective study was carried out on 108 patients of acute stroke, both ischemic and hemorrhagic stroke, admitted within 24 hours of symptom onset at the center. ABPM, 3 casual BP recordings and functional assessment using modified Rankin scale was done on the day of admission, day 6 and 1 month follow-up. And what was the result of the study? The mean age of patients was 65.57 plus minus 13.91 years. Majority were males, that is 71.3%. Ischemic stroke was the commonest type of stroke in this study in 90.7%. Hypertension was present in 20% of ischemic stroke patients and 60% of hemorrhagic stroke patients. And this association was statistically significant, p-value 0.012. The patients with hemorrhagic stroke had significantly higher casual systolic blood pressure and diastolic blood pressure on day 1 and day 6 compared to those with ischemic stroke. In terms of nocturnal BP pattern, among patients of ischemic stroke, non-dipping pattern was most common, seen in 56.12%, whereas in hemorrhagic stroke patients, reverse dipping was common, seen in 70%. This association was found to be statistically significant with a p-value of 0.001. 74% of dippers had a favorable outcome at day 6 compared to 65% of non-dippers and 52% of reverse dippers. However, 100% of dippers showed a favorable outcome at 1 month, indicating a statistically significant relationship between dipping status and neurological outcomes. Thus, higher mean values of 24-hour systolic blood pressure, daytime SBP, nighttime SBP were significantly associated with poorer modified Rankin scores at day 6 and 1 month. Casual systolic blood pressure recordings on day 1 were also negatively affecting the MRS scores. So, what's the take home message from this article? ABPM can act as a useful tool for risk stratification in patients of acute stroke. So, this brings us to our next article. The next study is entitled Deep Cerebral Venous Thrombosis Clinico-Radiological Profile and Treatment Outcomes in Indian Population, a Tertiary Care Experience. This is by Sheetal Goyal et al. This was a retrospective observational study from December 2018 to January 2023. The cases with imaging data suggestive of deep cerebral vein thrombosis were included. This retrospective observational study was conducted at a tertiary healthcare center in South India. The neuroradiological assessment was performed using multimodality imaging to determine the location of parenchymal changes and also the number of deep veins involved in isolation or with the superficial dural venous system. The clinical variables were tabulated. Cases with available MRI were included in the analysis, and CT changes, if available, were also analyzed. MR venography, if available, was reviewed for deep venous system thrombosis and concomitant dural venous sinus thrombosis. The post-contrast T1 weighted MRI were analyzed for filling defects within the deep vein and dural venous sinus. And what were the results? A total of 27 patients were included in the analysis. Male to female ratio was 13:14. Mean age 33.4 years. Range 21 to 75 years. All patients presented with headaches, N is equal to 27, 100%. Other clinical presentations included focal motor deficits in 13 patients, that was 48.1%, altered sensorium in 11 patients, that was 40.7%, seizures in 8, 29.6%, diplopia in 2, that was 7.4%, and fever in 1, that was 3.7%. Raised intracranial pressure was present in 14 patients, that is 51.8%, out of which only 2 were from the group of isolated deep cerebral venous thrombosis. The risk factors for the development of deep cerebral venous thrombosis were hyperhomocystinemia in 11 patients, iron deficiency anemia in 9, postpartum state in 6, chronic alcoholism in 4, oral contraceptive pills in 3, antithrombin 3 deficiency in 1, and infection in 1. 3 patients had no known causative risk factor. A vasculitis profile, including ANA profile and serum ANCA, was performed in 11 patients, and all of them were negative. The most common deep vein involved was straight sinus, 25 patients, followed by internal cerebral vein, that is 23 patients. All 27 patients received anti-edema treatment in the form of intravenous mannitol, anticoagulation therapy in the form of unfractionated heparin, followed by maintenance with warfarin in standard dosage to keep the INR in therapeutic range. Anti-epileptic therapy was instituted for patients with seizures as the initial presentation. The patients with iron deficiency anemia were treated with iron supplements. Those with hyperhomocystinemia received vitamin B12 supplements. A total of 14 patients were treated with injection edaravone. None of the patients underwent decompressive craniectomy or intravenous catheter guided thrombolysis, and no mortality was observed in this cohort. So, what was the conclusion? They concluded that a knowledge of diverse clinical presentations of deep cerebral venous thrombosis is important. Its neurovascular anatomy, imaging characteristics, along with prompt diagnosis and timely interventions, can assist in attenuating the risk of acute complications as well as long term sequelae. Extensive deep gray matter involvement in this condition is associated with neurological manifestations like altered sensorium and motor deficits, with increased severity of illness as measured by MRA score. The deep cerebral vein thrombosis can present with diverse clinical manifestations. It should be actively considered for imaging, especially in the presence of superficial venous thrombosis. Prompt diagnosis and treatment are crucial for achieving a favorable prognosis. Unilateral or bilateral thalamic hypodensity on CT or signal changes on MRI should definitely raise a suspicion of deep cerebral venous thrombosis, particularly in appropriate clinical context. Further evaluation with MR venography is recommended to confirm the diagnosis of deep cerebral venous thrombosis. Medical management typically includes anti-edema measures, anticoagulation therapy, and treatment of underlying hypercoagulable states. And the study also showed that surgical and endovascular interventions are rarely necessary in cases of deep cerebral venous thrombosis. So again, the next article is from the neurology domain, and the study is entitled The Pattern of Non-Motor Symptoms in Patients with Idiopathic Parkinson's Disease in a Tertiary Care Hospital of Rural Eastern India. And the author is Jaideep Majumdar et al. This study explores the non-motor symptoms of idiopathic Parkinson's disease and their relationship with disease severity. The Parkinson's disease is traditionally characterized by motor symptoms like tremors, rigidity, and bradykinesia. However, the non-motor symptoms, including neuropsychiatric, autonomic, sleep-related, and gastrointestinal issues, they significantly affect the patient's quality of life but are overlooked in most clinical settings. This study involved 65 patients over an 18-month period in a rural tertiary care hospital, and in this study, the disease severity was measured using the Hoehn and Yahr scale and a validated Parkinson's disease non-motor symptom questionnaire, which was used to assess the presence and frequency of these symptoms. Now, what were the key findings? The prevalence of non-motor symptoms was significant, with the most common non-motor symptom being low mood, 93.8%, apathy, 90.7%, impaired concentration in 89.2%, restless leg syndrome in 83%, and tenesmus in 83%. The neuropsychiatric symptoms, that is, low mood, anxiety, delusions, and hallucinations, were frequently observed and were correlated with disease severity. Autonomic dysfunction symptoms like nocturia, orthostatic hypotension, urinary urgency, and excessive sweating also showed a strong correlation with the progression of disease. Sleep and sensory issues like restless leg syndrome, vivid dreams, and sensory abnormalities like hyposmia were prevalent and statistically linked to disease severity. Gastrointestinal symptoms, that is cialorrhea or excessive salivation, dysphagia, that's difficulty in swallowing, constipation, and nausea, were common, and they became more frequent as the disease progressed. Significant symptoms in the study, it was found that there was significant correlation between the Parkinson's disease severity and symptoms like nocturia, orthostatic hypotension, reduced memory, delusions, and hallucinations. So what did the study conclude? It concluded that the non-motor symptoms are common in patients with idiopathic Parkinson's disease, and they become more pronounced as the disease progresses. Hence, early recognition and management of these symptoms are crucial for improving the quality of life of patients. The study also highlights the lack of research on the prevalence of non-motor symptoms in rural India, underscoring the need for more focused studies in this area. This research sheds light on the importance of addressing both motor as well as non-motor symptoms in Parkinson's disease to reduce the burden on patients and also the burden on healthcare systems. The next study is titled The Role of Heart Rate, Acidosis, Consciousness, Oxygenation and Respiratory Rate Score, so-called HACOR, HACOR, in predicting outcomes of non-invasive ventilation in COPD patients. The author of the study is Raghuveer Singh et al. This was a prospective observational study conducted on 100 COPD patients with acute respiratory failure who were initiated on non-invasive ventilation or NIV. HACOR score was calculated at the start of NIV and after 1 to 2 hours, at 12 hours and 24 hours. NIV failure was defined as progression to invasive ventilation or death. NIV success was defined as liberation from NIV prior to hospital day 7 and not meeting the criteria for NIV failure. So what were the results? In this study, 100 patients with COPD and respiratory failure were enrolled. The mean age was 65.34 years with a standard deviation of 8.19. Male patients were predominant, N81. 89% of patients were smokers and remaining had exposure to biomass fuel. At the initiation of NIV, the median HACOR score was 3. In 13% of patients, there was NIV failure. In 17% patients in whom the HACOR scale at initiation was more than 5, so there were 17 such patients. And in patients with HACOR score more than or equal to 5, the NIV failure was 76.4% and the mortality was 41.1%. The area under curve AUC for prediction of NIV failure by HACOR score was 0.98 with a p-value of 0.05 or less. So what was the conclusion? This score, the HACOR score, which includes heart rate, acidosis, consciousness, oxygenation, and respiratory rate, has high sensitivity as well as specificity at initiation in prediction of NIV failure. A high HACOR score predicts a high chance of NIV failure. Obtaining a HACOR score at baseline makes it very convenient to assess the efficacy of NIV in patients with COPD. So this brings us to our next article, which is a review article entitled Gluconephrotic Syndrome, a Comprehensive Review. And the author of this article is Saurabh Sharma et al. This article provides an overview of diabetic kidney disease paradigm, explaining important aspects such as prognostic markers, clinical assessments, and therapeutic options. The importance of the term gluconephrotic syndrome is emphasized, highlighting the importance of understanding gluconephrotic syndrome in screening and diagnosis of nephrotic syndrome and its management. It outlines key components in clinical assessment of gluconephrotic syndrome. The gluconephrotic syndrome necessitates a refined approach considering the unique challenges posed by diabetic patients in the context of nephrotic syndrome. This article highlights how important it is to assess diabetes in every case of nephrotic syndrome and how important it is to assess albuminuria in every diabetic patient. So test every diabetic for albuminuria and test every nephrotic for underlying diabetes. That's the message from this article. Now, the next review article is entitled The Indian Experience with Vericiguat, a review based on case series by Upender Kaul. We all know heart failure is one of the important causes of morbidity and mortality across the globe. In India, heart failure is common in middle-aged population as compared to Western population, where most of the population is elderly. As per the present available statistics, heart failure is responsible for 1.8 million of hospital admissions annually in India. That's a huge number. Heart failure with reduced ejection fraction is the most common form of heart failure, and patients with HFrEF have high rates of hospitalization, in hospital death, overall mortality when compared to patients with heart failure with preserved ejection fraction. Heart failure continues to be a progressive clinical syndrome with poor prognosis, even though the chronic heart failure management has improved. Recurrent episodes of heart failure, each leading to reduced cardiac function, are characteristic of natural progression of heart failure. Although the current pharmacological treatment of heart failure is fairly effective, there is still a need to lower the residual risk of cardiovascular events and hospitalization. Vericiguat is a novel therapy that addresses endothelial dysfunction, which is a frequently unacknowledged aspect of heart failure. So the nitric oxide soluble guanylate cyclase or CGMP pathway is one of the primary signal transduction pathways that regulate the cardiovascular system. Vericiguat functions as a stimulator of this pathway, targeting the NOSGC CGMP pathway through a distinct mechanism that complements the existing heart failure treatments. Dr. Kaul has presented a review article based on the effectiveness of this drug in Indian patients in 4 different clinical profiles of heart failure. These 4 different clinical profiles are: first one, patient on all 4 drugs in maximally tolerated doses but still symptomatic or with a very high NT-proBNP level. So they are on goal-directed therapy for heart failure, all 4 drugs but still symptomatic. The second group is patients on, again, all 4 drugs in maximally tolerated doses, but they develop worsening heart failure. The third group is worsening heart failure patients requiring escalation of oral diuretics on outpatient management. And the last group is those patients who cannot tolerate all the 4 drugs or maximally tolerated doses of these drugs due to tolerability issues, that is hypotension, high creatinine, or hyperkalemia. So these are the 4 groups. Now, vericiguat is the first oral SGCS approved by US FDA in January 2021 and was also approved in India in February 2022. Vericiguat is recommended to be taken at 2.5 mg orally once a day with food. This dose should be doubled approximately every 2 weeks until the patient reaches the tolerated dose 10 mg OD, which is the maintenance dose. The main objective of the review article is to help the treating clinicians manage different patient profiles of worsening heart failure, such as those with frequent hospitalizations or emergency visits requiring diuretics or escalation of oral diuretics. The analysis concluded that management of worsening heart failure patients should be proactive, which includes early initiation of vericiguat during outpatient visits for patients who present with worsening symptoms or tolerability issues to goal-directed medical therapy, or even at pre-discharge level or at first follow-up for hospitalized patients, along with dose optimization of background heart failure drugs. Vericiguat should be the cornerstone for the management of patients with worsening heart failure or tolerability issues to GDMT, irrespective of location of care, whether home or hospital. The need of the day is to be aggressive in the management of heart failure, especially in those presenting with worsening heart failure. The 4 pillars of heart failure management need to be upgraded to quintuplet therapy once the earliest signs of worsening heart failure have been detected. So this is an important study on vericiguat. Now our next article is an update article titled, "Does Adopting Western Low-Density Lipoprotein Cholesterol Targets Expose Indians to a Higher Risk of Cardiovascular Events?" This article is an expert opinion from Lipid Association of India, which comprises the opinion of stalwarts in the field of medicine and cardiology. And this is by Raman Puri et al. The article comments on how the adverse cardiovascular outcomes have declined in the Western countries due to aggressive risk factor control, including control of dyslipidemia. The American and European dyslipidemia treatment guidelines have contributed significantly to the reduction of ASCVD incidence in respective populations. However, their direct extrapolation to Indian patients is inappropriate for several reasons. In the US, the mean LDL cholesterol levels have markedly declined over the last 2 decades, correlating with a proportional reduction in CV events. Conversely, poor risk factor control and dyslipidemia management have led to increased CV and coronary artery disease mortality rates in India. The population attributable risk of dyslipidemia is about 50% for myocardial infarction, signifying its major role in cardiovascular events. In addition, the pattern of dyslipidemia in Indians differs considerably for that in the Western population, requiring unique strategies for lipid management in Indians and also modified treatment targets. The Lipid Association of India recognized the need for tailored LDL targets for Indians and recommended lower targets compared to Western guidelines. For individuals with established ASCVD or diabetes with additional risk factor, an LDL cholesterol target of less than 50 milligram is recommended and less than 30 milligram for very severe risk factors. This article focuses on how Indian dyslipidemia is different from the Western world and how dyslipidemia increases the severity of atherosclerosis in Indians and South Asians. Hence, the need for lower levels of target values of LDL cholesterol has been highlighted in this article, which certainly will be of great use to the postgraduate students and practicing physicians and cardiologists. Now, the last article of this issue is a position statement. Association of Physicians of India, the National Expert Opinion in Clinical Practice Recommendations on Primary Care Cough Management in India by Agam Vora et al. The objectives were formulation of recommendations for general practitioners to enable them to appropriately screen and categorize cough for the efficient management and to avoid irrational treatments. And what were the methods? An expert panel consisting of 7 experts specializing in pulmonology and internal medicine held a virtual discussion to assess the necessity for cough categorization and to develop user-friendly tools along with a simplified format for history taking in cough evaluation and management. Panel discussions were based on questionnaire that contained items related to the categorization of cough, assessment tools, and approaches to treating cough. The results, after deliberations, simplified clinical practice recommendations and assessment tools were developed by the experts to facilitate the categorization of cough into wet or dry categories, thereby helping in symptom-based management of this common clinical condition. And the conclusions were, by adhering to these principles and by using the assessment tools, the primary care practitioners can optimize cough management, avoid irrational drug combinations, minimize potential risks, and improve patients' well being. So that was the last article, and this is goodbye from my side. I really thank the JAPI for this opportunity and thank all the listeners. Hope you had a fruitful session, and thank you for listening to the wonderful JAPI podcasts. Thank you very much and goodbye.